Hey guys, welcome back everyone. We are continuing our Farre series, frequently asked and regularly repeated exam questions. And here in session, we will be discussing the important exam questions from neurology. Of course, we have put our efforts and collected the questions from various universities. And in this session, I will teach you how to write answers for the university questions from the subject of medicine focused on neurology. Okay, so there are some 6 or 7 important questions that can be asked for 10 marks or sometimes for 5 marks. And that's what we will deal today. I will not take much of time. I'll start with the question directly. So this is going to be our first question. Define Guillain-Barré syndrome or GB syndrome. Describe its types, clinical features, management. Usual question, very common, and for 10 marks. So if this question comes to us, how the examiner is going to divide the marks, right? For the definition, generally examiners will give 2 marks. For the type, 3 marks, that makes it 5 marks. The clinical features for 2 marks and management will carry 3 marks. And when I say management, that should include the diagnosis and treatment part. That completes our 10 marks. If you touch the key points, you will definitely get 7 or 7.5 marks comfortable, right? We will begin with the definition. Now, what is GB syndrome? Whenever we define a neurological disease, there are some elements we should focus on. The definition should include in the neurological hierarchy which structure this particular disease is affecting. Is it a disease of the peripheral nerve? Is it a disease of the cranial nerve? Is it a disease of the spinal cord? Is it a disease of the brain? If brain, is it a disease of motor cortex, sensory cortex, prefrontal cortex? What region it is? Right. Now, GB syndrome is a disease of peripheral nerve. So how will we define it as? GB syndrome will be defined as a infection triggered. That means there is some infection which is triggering it, but this is not an infectious disease. Means infection is not directly causing the neurological problem. Infection is just a trigger factor. So we will define it as infection triggered inflammatory, and you can definitely also count it as autoimmune, because infection is triggering inflammation means it is autoimmune disorder of peripheral nerves presenting as, so this is a disorder of peripheral nerves presenting as rapidly progressing ascending flaccid paralysis. So there are few terms that I want you to focus on while you write. These are the terms that examiner is looking for. What are the terms he is looking for? The first term he is looking for is, you should mention that this is an autoimmune disorder. It is triggered by an infection. It is a disorder of the peripheral nerves. In bracket, if you want, you can also write that this is a polyneuropathy, means single peripheral nerve is not affected, diffuse involvement of multiple peripheral nerves. It is a polyneuropathy. And then examiner is looking for how the patient is going to present. First word he is looking for is paralysis is ascending, means it is starting in the distal most parts of the body, mainly in the lower limbs, and then progressing proximally. Ascending paralysis. And to indicate that you know the stuff well, that it is a disorder of the peripheral nerves, examiner is also looking for the flaccid term in your description. Okay, what is the meaning of flaccidity? Decreased tone or hypotonia. Hypotonia indicates damage to lower motor neurons. And where do I find the lower motor neurons? In the peripheral nerves, right? Beginning in the anterior horn of the spinal cord, lower motor neurons are found in the peripheral nerves. So that's why these terms are important. As long as you're mentioning these terms, your definition is complete, and definitely examiner will give you 2 marks. Okay. Now, what is the etiology, right? When I say, I have already mentioned that this is an infection triggered autoimmune disorder. So we have to primarily mention the infections which are responsible. I strongly consider that examiner must or might ask this question this time, because GB syndrome is in the news because of the Pune incidents, right? So it is usually triggered by, the trigger is usually bacterial infections are more common than viral infections. And when it comes to the bacterial infections, you should mention that most commonly it is the gastrointestinal infections. Most commonly gastrointestinal infections. GI infections are known to trigger, followed by respiratory infections, followed by respiratory infections. And here we can also mention that the most common GI infection responsible for the GBS is Campylobacter jejuni, which is known to cause dysentery. Campylobacter jejuni, that is the most common GI infection. So here 2-3 things that examiner will be looking. You should mention that these are triggers for the infection, immune attack on your peripheral nerves. GIT infections are typically responsible in majority of the cases. And among the GIT infections, it is the Campylobacter jejuni, which is most commonly responsible. Okay. If you want, you can definitely write a little bit about the pathogenesis, if you have time, just to get the half marks extra. Pathogenesis. So basically what happens is you have an infection, most commonly which infection? Campylobacter jejuni. And after the infections, usually 1 to 3 weeks, there is production of antibodies. Like what antibodies are known to cause GB syndrome? You can mention anti-GM1 antibodies. Now, what is this GM1? GM refers to gangliosides. So basically, there are different types of gangliosides, and the M1 type is one of the antigen which is being targeted by our own immune system, or anti-GD1 antibodies or anti-GQ1 antibodies. These antibodies will lead to demyelination or axonal injury. Axonal injury. So these antibodies are supposed to destroy the infecting organisms, but because of molecular mimicry, they are targeting your own neurons. Either they strip the myelin sheath of the neurons, or they cut the axons, means they cause the damage to axons. This is in simple the pathophysiology. Now, what clinical features these patients are going to present? These patients will present with, first, rapidly progressing ascending paralysis. Ascending paralysis. This is a statement that you should write. You can describe, if you have time, what is the description? Weakness begins in the lower limbs. Begins in the lower limbs and ascends upwards. And ascends upwards. Okay. So that is the nature of weakness, but clinical features don't stop there. Why? Because on examination, what findings I'm going to get? So I want you to remember here that we're talking about a disease which is affecting the peripheral nerves. Hello everyone. Hello everyone. But Amir, I will just check on that. I will ask the team to load it. Shubham Pandey, I will also follow up whether the rheumatoid and hemat are missing. Okay. So now, remember, we're talking about a disease which is affecting all your peripheral nerves, diffuse involvement of peripheral nerves. Okay. Now, peripheral nerves not only contain motor neurons. Remember, our peripheral nerves have motor neurons. What is the function of motor neurons? Bring the information from the brain to your muscles for contraction whenever we need to do any movement, right? But also, our peripheral nerves are carrying the sensations from the peripheral parts of the body to the brain, right? So peripheral nerves also contain sensory neurons. Sensory neurons. And our peripheral nerves also contain autonomic neurons. Autonomic neurons. Because remember, when I touch cold objects, hot objects, there is expected vasoconstriction, vasodilatation response, which is done by autonomic nervous system. So those autonomic neurons also have to reach the peripheral parts of the body. They are reaching through peripheral nerves. So when a disease affects the peripheral nerves diffusely, it may affect all the three structures. I'm not saying GB syndrome is a motor neuropathy. I'm not saying GB syndrome is a sensory neuropathy. GB syndrome is a peripheral neuropathy, right? Polyneuropathy. It affects all these. So motor neuron involvement explains why we have paralysis. But there will be involvement of sensory neurons and there will be involvement of autonomic neurons. So what other symptoms I can expect because of that, right? So this is one thing. Here in the bracket you can write due to involvement of motor neurons, involvement of motor neurons, motor neurons. Then I can also have another symptom, peripheral sensory loss. So we can also have ascending mild sensory loss, mild sensory loss. The term that you have to focus here is mild, highlighted for the examiner so that he knows that you know the stuff. And in the bracket you can write due to involvement of sensory neurons, sensory neurons. And the third thing that GB syndrome can lead to, there is also autonomic neurons, right? So involvement of autonomic neurons. Autonomic neurons in the body are responsible for vasodilatation, vasoconstriction. Apart from that, they're also responsible for your heart rate regulation, right? You know, the sympathetic can increase your heart rate, parasympathetic can decrease it. Unfortunately, typically when the neurons get damaged, it is the parasympathetic which are most vulnerable compared to sympathetic. So parasympathetic get affected more than sympathetic. Parasympathetic is down, sympathetic is now up. So heart rate can increase, right? So we can have a resting tachycardia, resting tachycardia due to autonomic neuron involvement, autonomic neuron involvement. So these are the three features that you should write in terms of symptoms. So before this interruption, we were talking about the GB syndrome. I will just quickly summarize what we have discussed and then we will begin again. In the GB syndrome, first we have to begin with definition. GB syndrome is a disease of the peripheral nerves affecting all your peripheral nerves collectively. It's a polyneuropathy condition. So in your definition, you have to mention that it is a polyneuropathic disorder. It's a polyneuropathy. Then you should mention that it is an autoimmune disorder triggered by an infection. And then you have to also describe that once the GB syndrome happens, patient present with rapidly progressing ascending paralysis. So when these three terms, ascending paralysis, peripheral neuropathy, and autoimmunity are mentioned in the definition, your definition is complete for 2 marks. In terms of etiology, we know that it is an autoimmune disorder triggered by an infection. So primarily we have to write 1 or 2 points about infection. Infections, generally bacterial are more commonly known to cause GB syndrome than viral. And among bacterial, it is the gastrointestinal infections which are more common. And among the gastrointestinal infections, it is the Campylobacter jejuni infection which is more common. This much you can mention, it is more than enough. If you want to write, you can mention 2 statements in pathogenesis. First is that infection leads to production of antibodies against the bacteria or the viruses. But these antibodies, because of molecular mimicry, end up damaging your axons or the myelin sheath. So injury can be either to myelin sheath or axons. In terms of clinical features, we have to mention 3 symptoms. First one, because of the damage to motor neurons, patients will have weakness. The weakness is ascending type, starts in the distal most parts of the body, that is your feet, and then ascend upwards. Second, there will be involvement of sensory neurons. Patients can have mild ascending sensory loss. Third, there will be involvement of autonomic neurons that can lead to resting tachycardia. Patients with GB syndrome, when you check their heart rate, it is usually more than 100 because of the involvement of autonomic neurons. Okay. Now this is about symptoms. In the clinical features, we have to also mention about the examination findings. So what are the examination findings we can get? So on examination, in neurological examination, we describe 3 or 4 things. The first thing that we will describe is the motor strength of the muscles. Second thing we will describe is the deep. Okay, sorry for the interruption again. There are little issues with the power, but I think it's sorted. So we were talking about examination, and when we describe examination, we are supposed to describe 3 things. First, motor system. In the motor system, strength of the muscles. Second, we have to describe the deep tendon reflexes, and third, tone. Apart from that, sensory system examination and higher mental functions. Right. So on examination in these patients, we have to write motor system, what is happening with motor system. Then we have to write what is happening with the sensory system, and then we have to write what is happening with the higher mental functions. Higher mental functions. So motor system will show that there is, in terms of strength of the muscles, decreased in lower limbs because they are getting affected first. Then when you see the deep tendon reflexes, we are talking about a disease which is affecting the peripheral nerves. Peripheral nerves contain, always remember, I will make a note here, peripheral nerves contain lower motor neurons. And whenever there is damage to lower motor neurons, what happens to the deep tendon reflexes? They become decreased. Whenever there is damage to lower motor neuron, what happens to the tone? It becomes decreased. So simple way to remember about the tone and deep tendon reflexes is lower, everything goes down. Tone decreases, deep tendon reflexes decrease. Upper, everything goes up. Damage to upper motor neuron leads to increase in tone, increase in deep tendon reflexes. So deep tendon reflexes will be decreased or absent. Decreased or absent, which you can also write as hyporeflexia or areflexia. You can write it as hypo or areflexia in lower limbs or the affected parts, right, in lower limbs. Then next is tone of the muscles. Tone will be diminished or absent. So you can say that there will be hypotonia. Hypotonia. What words examiners are looking for? Examiners are looking for hyporeflexia, areflexia, or hypotonia in lower limbs. In lower limbs, the tone will be decreased. So that explains what happens to the motor system. Then the sensory system examination, there will be mild sensory deficits in lower limbs. In lower limbs or the affected parts of the body. Okay. Higher mental functions. This is a disease of the peripheral nerves, not a disease of the central nervous system. So higher mental functions are unaffected. So your patients of GB syndrome are generally going to be conscious oriented. It is not affected. Okay. So that is about the GB syndrome. Now coming to its types and diagnosis. How do we classify the types of GB syndrome? The types of GB syndrome is classified based on nerve conduction study findings. So basically what happens is the disease may be affecting the axons or the myelin sheath. Because when I say peripheral neuropathy, means we're talking about a disease affecting peripheral nerve. The damage may be only to axons, only to myelin sheath, or both. So depending on that, we classify the GB syndrome into different types. So I just want you to put this flow chart classifying it. The first and the most common is AIDP, which stands for acute inflammatory demyelinating polyneuropathy. Acute inflammatory demyelinating polyneuropathy. Demyelinating polyneuropathy. So here it is a demyelinating type of the GB syndrome where damage is to the myelin sheath, right? It is the point that we need to write about it is the most common type, accounting for 80 to 85% of cases, and it is due to, see, I have already told you that there are different types of antibodies which are causing the damage. Some antibodies cause myelin damage, some antibodies cause axon damage, some antibodies cause both the damage. So the kind of damage that we are getting here is the deep myelin damage. It is because of the antibody which is known as anti-GM1 antibodies. It is due to anti-GM1 antibodies. So any infection that activates anti-GM1 antibodies, you will end up causing demyelination and you will be present with AIDP. Then the second type that we have is called as AMAN. AMAN refers to acute motor axonal neuropathy. Means here the injury is to the axons, not the myelin sheath. So this is an axonal injury type, right? Now it is due to anti-GD1 antibody. Anti-GD1 antibody. And I want you to write an extra point here. I have already mentioned that GB syndrome generally carries sensory symptoms, motor symptoms, and autonomic symptoms, right? 3. But this is one variant where you don't get sensory or autonomic symptoms, only motor. So that's why it is a pure motor variant of GB syndrome. Pure motor variant of GB syndrome. Okay. Then we have one more type called as AMSAN. AMSAN, which refers to acute motor and sensory, acute motor and sensory axonal neuropathy. So here the disease is affecting both motor as well as sensory, but the nature of injury is axonal, right? It is causing the damage to axons. And then the last one we have is called as Miller-Fisher. Miller-Fisher variant or Miller-Fisher type of GB syndrome. Now this is one GB syndrome. I want you to write one extra point here. It is characterized by ataxia. Characterized by ataxia. And the antibody that we see here, it is due to anti-GQ1 antibody. It is due to anti-GQ1 antibody. So what points examiners are looking for in the answer? They are looking for the name, AIDP, Aman, AMSAN, and Miller-Fisher in the classification. That will give you 1 to 1.5 marks. And then they are looking at whether you mention the antibodies involved. That's it. That completes our classification of GB syndrome for the exam. Next up is the diagnosis. Now what I should write in the diagnosis? Diagnosis is mainly clinical, supported by laboratory investigation. Means we're not totally dependent on the laboratory investigation for the diagnosis of GB syndrome. So essentially, right, what features are required for diagnosis? What features are required? Patient should have ascending paralysis plus hypo or areflexia, because ascending paralysis can also happen because of the spinal cord compression. So to differentiate that from this, we need to have hyporeflexia or areflexia plus hypotonia. So when these three things are together in any patient, it is a case of GB syndrome until proved otherwise. There are other rare causes, but for an undergraduate student, it is more than enough. But in terms of investigation, what I should write? Right, I want you to write few words about the CSF analysis in the investigation. And the second thing I want you to write, the investigation of choice is the nerve conduction study. Nerve conduction study can tell us whether it is the demyelination type or axonal injury type, which we have used for the classification. Examiners are not looking at notes on the nerve conduction study, just mention it. But CSF analysis, we are looking for one point. What is it? What happens in the GB syndrome? In GB syndrome, antibodies reach into the CSF and try to damage the anterior horn cell, which is the cell body of the lower motor neurons in the spinal cord. Because of that, there is elevation in the protein in the CSF, because antibodies are what? Immunoglobulins. Immunoglobulins are what? Proteins, right? So there will be increased CSF protein, and the cell count is usually normal or minimally increased. For simplicity, you can write it as normal. Normally in meningitis, what happens? Both CSF cell count as well as protein increases. In encephalitis, both increase, but here only one is increased, the other is not increased. So this condition we will call it as albuminocytological dissociation. Albuminocytological dissociation. What does that mean? Protein is increased, but cell count is not increased. In various other CNS inflammatory conditions, both are increased. So they are now separated, not following the same direction. This is what examiner is looking for in the answer. So please mention that there will be albuminocytological dissociation. So once we have written this, our description of diagnosis is complete. Now we have to talk about the management or treatment. Okay, so in the management, we have to mention that there are two treatment options available. Basically, it is an autoimmune disorder where your antibodies are damaging your neurons, myelin or axon. So I want to quickly silence those antibodies so that the damage stops there. How do I do that? Well, one, I can remove the antibodies from the body. Removal is through plasma exchange or plasmapheresis. or I can neutralize those antibodies by giving IV immunoglobulins, right? Like there are enemy soldiers in our army, in our land, and we send our army to finish them. That is our IVIG, right? Or plasma exchange. These are the two options we have. So first one, you can write plex or plasma exchange or plasma pheresis. And second thing you can write is IV immunoglobulins. IV immunoglobulins. In a theory answer, nobody is expecting you to write which one is better, which one is inferior, what are the comparative trials, and just mention these two treatment options are there. And in terms of complications, that closes our answer. What complications GB syndrome can lead to? Can GB syndrome lead to death? Yes, it leads to death. So complications include respiratory failure. And the second one, see, I have already told you that autonomic nervous system is getting affected. That's why heart rate is high, and excess activity of sympathetic nervous system can lead to arrhythmias. So it can also lead to ventricular tachycardia or ventricular fibrillation. And both of them contribute to death, right? So that can lead to death. So that completes the description of the GB syndrome. I think I have highlighted the key points that you have to write in the answer. Now we will go to the next question, which is on myasthenia gravis. So myasthenia gravis, most of the universities, they ask it as a 5-mark question, but sometimes it can also be a 10-mark question. We'll try to address whether it is asked for 5 or 10. So if it is a 10-mark question, how will we distribute the marks? First, they will ask what is myasthenia gravis or define. For that, generally 1 mark is given because the definition is not complex. Then description of the clinical features, usually 3 to 5 marks for the clinical features. Investigations, usually 3 marks for the investigation, and management 2 marks. That's the usual description. Sometimes there can be an added question like how to differentiate between cholinergic and myasthenic crisis, right? So let us begin with the definition. I've already told you, whenever we write a neurological disease definition, the definition must include anatomical localization. This disease affects which structure in the hierarchy of the nervous system? Is it a disease of peripheral nerves, neuromuscular junction, muscle, spinal cord, brainstem, or brain, right? So myasthenia gravis is it's an autoimmune disorder, just like the GB syndrome. It's an autoimmune disorder affecting what structure? Of course, the neuromuscular junction. But when we describe the neuromuscular junction, we know that neuromuscular junction means there is a nerve terminal and then there is a muscle, right? There is a nerve terminal and the muscle. Whether it is affecting the nerve side of it or the muscle side of it. Something that is affecting the nerve side of it is called as presynaptic NMJ disorder. Something that affects the muscle side of it is called as postsynaptic NMJ disorder. Now it is a disorder that is affecting the acetylcholine receptors, right, which are postsynaptic. So this is a disorder affecting the postsynaptic neuromuscular junction. So as long as the examiner sees this word in the definition, he is pleased. He will definitely give you the mark for the definition. Presenting as, how will these patients present? Presenting as weakness, which is worse, whether in the morning or evening, worse in the evenings, or you can also write towards the end of the days, or you can even make the definition more professional by writing presenting as fatigable weakness. Means the more I do the physical activity, the more weak the muscle becomes, the fatigable weakness, right? Or after the definition, we can mention that it is characterized by fatigable weakness, or you can also use the term weakness as diurnal variation of weakness. There is diurnal variation of weakness. Unlike a case of stroke or GB syndrome, who will have the same level of weakness whether we are seeing them in the morning or evening, GB syndrome or NMJ disorders are not like that. GB syndrome patients are kind of energetic in the morning, but as the day progresses, they become progressively weak, and they have terribly weak weakness of the muscles in the evening, right? Okay, so what clinical features they present with? We did not discuss about the etiology, right? Etiology. pathogenesis. So under this heading, let us describe first the risk factors. It is an autoimmune disorder, then there are definitely certain risk factors. What are the risk factors? Of course, for most autoimmune disorders, female gender is a risk factor. Females, middle age, and having thymus gland tumors or thymomas. These are well established risk factors. Okay. Then what is the pathogenesis? So primarily in the thymus gland, we have something called as myoepithelial cells. Myoepithelial cells means epithelial cells which also act like muscles, right? Cells which have properties of epithelium as well as the muscle, myoepithelial cells. And these myoepithelial cells contain acetylcholine receptors, right? So once they are hidden from your immune system, but once they are exposed to circulation, results in formation of anti-acetylcholine receptor antibody, and these antibodies result in NMJ blockade, and that is how we end up getting the myasthenia gravis. It's a very simple pathogenesis for recreating in the exam. More detailed pathogenesis, of course, we'll discuss when we discuss the MCQ perspective. Okay. Now, what clinical features a patient of myasthenia gravis will present? I've already told you that when you write the clinical features, you have to write what happens to the motor system, what happens to the sensory system, and what happens to the higher mental functions. This is a disorder of NMJ, not a disorder of CNS. So higher mental functions unaffected. This is a disorder of neuromuscular junction. Sensory nerves are not affected, so no sensory deficits, pure motor symptoms. Right? So first thing, motor symptoms. What motor symptoms we get? The earliest motor symptom is going to be, what is the earliest motor symptom? It is going to be ptosis. Why ptosis is the earliest motor symptom? Remember, I have made one statement for myasthenia types. The more I use the muscle, more weak it becomes, because more acetylcholine gets expended और खर्च हो जाता है acetylcholine, तो फिर acetylcholine receptors को bind करने के लिए कम पड़ जाता है. The more I use the muscle, more weak it becomes. And in the body, which muscle is most commonly used? Most used, your levator palpebrae superior, because हम constantly blink कर रहे हैं, तो we are using it, and because of that, that becomes the weaker first, right? And what other symptoms I can expect, or if you want, you can write the sequence of involvement. So the earliest muscle that is going to get affected is the levator palpebrae superioris, followed by that. और कौन सा muscle हम सबसे ज़्यादा use करते हैं? The eyeball muscles or muscles of extraocular movement, because constantly we are seeing here, there, up, down, everywhere, right? So extraocular muscles, followed by that we use our proximal muscle, right? Brush करने के लिए, खाना खाने के लिए, comb करने के लिए, for everywhere we are using our proximal muscles. So we will have involvement of proximal muscles, followed by that facial muscles. Facial muscles. So we can now comfortably describe what clinical features we can get, as long as you remember this sequence, right? So involvement of levator palpebrae superioris leads to ptosis. Then once the extraocular muscles also get affected, it leads to diplopia. Then proximal muscle involvement leads to what is called as proximal myopathy or proximal muscle weakness. And facial muscle involvement leads to facial drooping. And the facial drooping makes them look, when you ask them to smile, their face looks like the snarling dog. So you can also write it as snarling faces. You remember. Nobody is expecting you to write it, but if you remember, you can write the snarling faces. Okay. So that's about the clinical features. In the clinical features, the motor symptoms, we have to mention that these symptoms are worse as the day progresses. It's very, very important. Okay. Now with that, our clinical features description is complete. Now let us talk about diagnosis. How will I make a diagnosis of a patient with myasthenia gravis. Anyone presenting with weakness which is getting worse on evening is a clinically it is a case of myasthenia gravis, but I have to go ahead and confirm, right? So it is, if you have to ask me what is the preferred investigation for diagnosis, preferred investigation for diagnosis is going to be single fiber electromyography or the repetitive neurostimulation test. Single fiber electromyography. Basically, what we are trying to test in this is repeatedly stimulate a single muscle fiber and see what happens to its force of contraction. If it is myasthenia gravis, I've already told you, the more I use the muscles, the more weak it will go on becoming. So if I repetitively stimulate, force of contraction should go on decreasing, right? So we will call this investigation a single fiber electromyography, single fiber electromyography or SFEMG. SFEMG, or because this is a cumbersome procedure, instead we can also do repetitive nerve stimulation study. Repetitive nerve stimulation study. दोनों में कुछ फर्क नहीं है. In one, we are stimulating the muscle fiber directly. In the repetitive nerve stimulation study, or you can write it as RNST, we are stimulating the nerve. And nerve, of course, will take the signal to the neuromuscular junction and try to contract the muscle. The more I use the muscle, the weaker the muscle will become, right? So what I should write here on this study, I will see decremental response. What does that mean? After repetitive stimulation, the muscle's contraction goes on decreasing. If it goes on increasing, it is suggestive of the presynaptic NMJ disorders. For example, your Lambert-Eaton syndrome. Okay. Then what other investigations I can do? For screening, this is a prepared investigation for diagnosis, but for screening, we can use something called as ICE-PAC test. ICE-PAC test. What I should write about the ICE-PAC test? The ptosis improves on applying ICE-PAC. On applying ICE-PAC. So basically, these patients' eyes, we try to close it with an ICE-PAC, giving the rest to the levator palpebrae superioris muscle. The more I use, the more weaker it becomes. The more rest I give, the more stronger it becomes. So the ptosis will disappear. Okay. What other investigations we can do? We can also do anti-acetylcholine receptor antibody test. The point you should write about it is the most specific investigation. Most specific investigation. Okay. Then we can also do edrophonium test or tensilon test. Edrophonium test, also called as tensilon test. Now, what is the interpretation of this test? So, after administration of edrophonium, tensilon or physostigmine, what are they? They are acetylcholine esterase inhibitors. So, remember now that in the neuromuscular junction, the antibodies have bound the acetylcholine receptors. These acetylcholine receptors are bound by the antibodies. Now, if I have to displace the antibody from this binding site, I have to release more acetylcholine, because acetylcholine and antibodies are in competition. There's a competitive inhibition. So, if I increase acetylcholine, they will win the competition and they will be able to bind the receptor and the muscle will contract. So, how I can increase acetylcholine? I can't make the nerve release more acetylcholine. I don't have that pharmacological luxury right now. So what I can do is, I know once this acetylcholine is released, it gets converted to choline by an enzyme called as acetylcholine esterase. So if I block this, the amount of acetylcholine will by default increase. So by doing that, I can help the competition lean in favor of acetylcholine instead of antibodies. That's the basic rule, right? So this edrophonium or the physostigmine, they are nothing but acetylcholine esterase inhibitor, right? So if I administer acetylcholine inhibitor, acetylcholine will increase and the symptoms of myasthenia gravis will improve or resolve. So there you can write that ptosis improves on administration of edrophonium. Okay, so that completes our investigation part. 2-3 points, right? What you have to write? The preferred investigation is SFEMG or RNST. Screening ke liye we can use the ICE-PAC test. Anti-acetylcholine esterase antibody, anti-acetylcholine receptor antibody is the most specific investigation. Hydroconium test is also available, not routinely done these days. Okay. So once we have diagnosed, then comes the question of management. Now in the management, I want you to write a flow chart describing what all can happen to a patient with myasthenia gravis. The myasthenia gravis patients can also get into a very critical situation when their respiratory muscles also become weak. So myasthenia gravis, we will divide them into two groups. An MG patient who has respiratory weakness and who does not have respiratory weakness. So without respiratory failure, with respiratory failure. So without respiratory failure, we will call them as chronic stable myasthenia gravis. And those who are having respiratory failure, we will call them as myasthenic crisis. Myasthenic crisis. Okay. So the management of these two patients are going to be different. First, we will address the more emergency, which is the myasthenic crisis. So in the myasthenic crisis, respiratory muscles are not working. So patient saturation is going down. He is going to die soon. So what should be my first step, right? So first step is monitor forced vital capacity so that you know when to put this patient on ventilator. Second, mechanical ventilation at appropriate time. Mechanical ventilation at appropriate time, right? Then third, now I have to quickly remove the antibodies that are circulating in this body, because antibodies are competing at even the respiratory muscle level, and respiratory muscles are not able to work. So if I remove the antibodies from the body, respiratory muscles are liberated and they will start working again. So how can I do that? By doing plasma exchange or IV immunoglobulins. Remember, whenever we have to remove antibodies from the body quickly, these are our two treatment options. Okay. Now, on the other hand, for patients who are having no respiratory failure, right? In them, the first treatment is to increase acetylcholine. How can I increase the acetylcholine? By giving acetylcholine esterase inhibitor, right? And what is considered as the drug of choice? The drug of choice is pyridostigmine. Pyridostigmine. Okay, why pyridostigmine is the drug of choice for the myasthenia gravis patients? Why is it the drug of choice? Helix oram, that's what the respiratory muscles, including intercostals and diaphragm, are usually very late to get affected. But yes, they can get affected in at least few individuals. That's why I said some patients may present with respiratory paralysis either at the time of initial diagnosis, or a known case of myasthenia gravis sometimes may present with the respiratory paralysis because of involvement. There are two reasons why we are preferring pyridostigmine. Number one, it is long acting, right? I do not want to give short acting acetylcholine esterase inhibitor to these patients. Then patients' weakness will be like up and down. I took a short acting acetylcholine esterase inhibitor for a few minutes. I was energetic, action gone, I'm down. Again, I take energetic, action gone, I'm down. I don't want that to happen to my patient. I want the patient to have a smooth control of symptoms throughout the day. So I want long acting. Pyridostigmine is one. Second, where I want this acetylcholine to go up, in the CNS or in the neuromuscular junction, right? Pyridostigmine does not penetrate the blood-brain barrier. So that's why it will act more on the periphery, poor action on the brain, right? So it is long-acting and poor blood-brain barrier penetration. These are the two reasons why we prefer using the pyridostigmine. So acetylcholine increase, like we just studied that there is a competition happening between acetylcholine and the antibody for one receptor, right? Whether acetylcholine will bind to it or antibody will bind to it depends on what? Depends on their strength. If acetylcholine is more, acetylcholine will bind. If antibody is more, antibody will bind. So to make this balance still towards acetylcholine, I am trying to increase the acetylcholine. Good. Another thing I can do is decrease the antibody, so that clearly acetylcholine ends up winning it. So how I can decrease the antibodies? So to decrease antibody load. Here I'm not going for plasma exchange or IVIG because I'm not in an emergent situation, right? I don't have any urgency. I can slowly bring it down. So how can I bring it down? Which cells produce antibodies? Or B lymphocytes, plasma cells, right? I can suppress them by giving what? Steroids and immunosuppressants, right? So we can use corticosteroids or immunosuppressants. Of course, long-term use of steroids has side effects, so most of us end up preferring immunosuppressants like azathioprine, mycophenolate mofetil. Plus, what else we can do? I've already told you in the pathogenesis that the antigens against which body is producing antibodies stay in the thymus gland, right? They are in the thymus gland. If I remove the thymus gland, antigens are gone. If no antigen, body will not produce antibodies, and if no antibodies, they are not going to bind the acetylcholine receptors. As simple as that. So how can I do that? By removing the thymus gland. So we can consider doing thymectomy for acetylcholine receptor antibody positive patients. Antibody positive patients. So that completes our description of the management of myasthenia gravis. Now in the question we also had one more thing. How to differentiate between cholinergic crisis and myasthenic crisis, right? We just learned what is myasthenic crisis. What is myasthenic crisis? A severe form of myasthenia gravis where patient has ended up with respiratory failure, where we have to eventually put him on ventilator. Okay. Now, can a patient, so in this, what is happening? The acetylcholine is so low in comparison to antibodies that antibodies are winning the battle. Acetylcholine is very, very low. So you can simply treat it as an acetylcholine low state. Can high acetylcholine also cause the same problem? Yes. You might have studied about organophosphate poisoning where acetylcholine level is very high. That also causes why OP poisoning patients die because of respiratory failure. So excess acetylcholine can also cause respiratory failure, and acetylcholine deficiency can also cause respiratory failure. So if a patient of myasthenia gravis comes, how would I know whether he is having acetylcholine deficiency or excess? Because excess is also possible. I may be giving him too much of acetylcholine esterase inhibitor, pyridostigmine overdosage. In that case, acetylcholine will be high. That may also cause respiratory failure. So how will I differentiate whether it is overdosage of the pyridostigmine or whether it is the deficiency of acetylcholine? So we will put a table comparing cholinergic crisis versus myasthenic crisis So first thing we will write here is what is happening to the acetylcholine. In cholinergic crisis, there is acetylcholine excess. In myasthenic crisis, there is relative deficiency of acetylcholine. As much as we need, we don't have. Okay. So in terms of clinical features, both of them may present with respiratory failure, and that is why we need to know how to differentiate between the two, because both of them have respiratory failure as their symptom. Of course, I am not going to test patient acetylcholine level, so I have to decide whether it is cholinergic crisis or myasthenic crisis on clinical grounds. What will help me? We can look at patient's pupils. In cholinergic crisis, what happens to the patient's pupils? Like organophosphate poisoning, most of you would have seen in your hospitals. What happens to their pupils? Thank you, Azad. What happens to their pupils? Remember, acetylcholine excess, right, causes pupil constriction. And what is the antidote for the acetylcholine excess? Atropine, right? So what atropine causes? Pupil dilatation. So what we will see when there is cholinergic crisis, pupils will be constricted because acetylcholine is high. What do we call it as? We will call it as meiosis. On the other hand, pupils will not be constricted in myasthenic crisis because there is no excess acetylcholine. What else helps us? There is something called as sludge symptoms. Now, what do I mean by sludge symptoms? Sludge refers to salivation, lacrimation, urination, defecation, gastric symptoms, and emesis or vomiting. What does that indicate? Cholinergic excess or the cholinergic deficiency? Now remember, organophosphate poisoning, you might have seen those patients in your hospitals. They're powering fluids from everywhere. We used to say that OP poisoning patients drown and die in their own fluids. Because when acetylcholine goes high, it stimulates all your glands. It is a pro-secretory And so you start secreting a lot of fluids. So we'll see these symptoms in patients with cholinergic crisis, right? We will not see those symptoms in patients with myasthenic crisis. The last thing that can help us is the edrophonium test. Edrophonium test. So what is edrophonium? Edrophonium is a acetylcholine esterase inhibitor. So I've already told you acetylcholine gets converted to choline by acetylcholine esterase, and this gets inhibited by edrophonium. Okay. So now if I administer edrophonium, what will happen to the acetylcholine? It will increase. So what will happen to the symptoms of cholinergic crisis? Already patient has high amount of acetylcholine. By increasing it further, the symptoms of the patient will get worsened. On the other hand, in myasthenic crisis, there is deficiency of acetylcholine. By enhancing it, I will make the symptoms improve. So edrophonium test will show worsening of symptoms in case of cholinergic crisis, and improvement of symptoms in case of myasthenic crisis. Now you may be thinking, sir, why all this? It's very difficult to remember and all. It is important for a clinician because at least if I have treated some 50 patients of myasthenia gravis in my lifetime, at least one of them will some or the other day come with respiratory paralysis. And when he comes with respiratory paralysis, as a doctor, I have to judge whether the amount of pyridostigmine I am giving has gone overboard, excess, or he has underdosed the pyridostigmine, and that's why choline deficiency is there, and that's why patient is having myasthenic crisis. So I have to differentiate cholinergic versus myasthenic. And the first thing that will hold my hand is pupils. Pupils constricted, I know it is cholinergic crisis. And if pupils are not constricted, myasthenic crisis. Plus, if patient is throwing out fluid from everywhere, I know it is cholinergic crisis. Only in a condition where I'm not able to decide clinically, I will go for the edrophonium test. So that table completes our question on the myasthenia gravis. Again, a quick heads up, what all you need to write in the myasthenia gravis. Few words that examiners are constantly and consciously looking for. First is that you have to mention which structure disease it is. It is a disease of post-synaptic neuromuscular junction, right? Another thing that examiner is very keenly looking for in the answer is that you should mention that there is diurnal variation of the weakness. Weakness is more in the evenings. Risk factors, it is an autoimmune disorder, so it goes without saying, females, middle-aged, and presence of thymus, because thymus gland has the antigen for the antibodies. Okay. And in terms of clinical features, he is definitely expecting you to mention ptosis as the earliest symptom, and then he is also keen to see proximal muscle weakness being mentioned. Rest of the things, if you mention, good. If not, it's still fine. In terms of diagnosis, he is looking for preferred investigation, screening test, antibody role, and the edrophonium test. Management, he is looking for whether you mention the drug of choice or not, and rest of the things, if you can cook up around, it's more than enough. So that completes the question on the myasthenia gravis. Now we will go to our third question, which is on the classification of headache and migraine. It can either be about migraine or the tension type of headache, or sometimes even the cluster headache. Okay. So we'll start with the classification of headache. Classification of headache will carry 2 marks in a 10-mark question. And the short note on migraine will carry your remaining 8 marks. Out of that, the diagnosis will carry 3 marks and the management will carry 5 marks. And again, in the management, he is asking you to write about the investigation, acute management, and preventive treatment. So that completes your 5 marks. So investigation 1 mark, acute management 2 marks, and the preventive treatment 2 marks. Okay. So we'll begin with the classification of headache. In the classification mentioned, it is based on International Classification of Headache Disorders 3. Okay. So how do we classify the headaches? The headaches, according to this, are classified into 2 broad groups first. The primary headaches and the secondary headaches. We'll classify them as primary headaches and secondary headaches. Okay, so examiner is not looking at the description of these headaches, but it goes without saying that when we say secondary headaches, headaches are secondary to some other disorders like the brain tumor, bleeding in the brain, meningitis, fever. Primary headaches, headache itself is a diagnosis, something else is not the diagnosis. If I have meningitis, meningitis is a diagnosis, headache is just part and parcel of it. If I have fever, whatever is the cause for fever, typhoid, malaria, that is a diagnosis, headache is just part and parcel of it. But migraine, tension type, cluster, headache itself is a diagnosis. So all of them are going to come under primary headaches. Okay. So among the primary headaches, we will classify them into first tension type, second migraine, third trigeminal autonomic cephalgias, trigeminal autonomic cephalgias or TACs, autonomic cephalgias or TACs. We'll call them as TACs. And of course, that is not covered in these three. We will call them as either miscellaneous, or you can also write it as others. Miscellaneous or others. Okay. Classification doesn't end here. Few more layers. Migraine will be further classified into migraine with aura, migraine with aura, and migraine without aura, migraine without aura. This migraine without aura is also called as non-classical migraine, and migraine with aura is called as classical migraine. Classical migraine. Under this trigeminal autonomic cephalgia also, we have few entities. One of them is very familiar to all of us, that is cluster headache. Cluster headache. Then we have one more called as paroxysmal hemicrania. Paroxysmal hemicrania. Paroxysmal means intermittent, hemi means one side, pain affecting only one side of the cranium. And then we have third, which is called as short-lasting unilateral neuralgiform cephalgias with conjunctival tearing, or SUNT, or short-lasting unilateral neuralgiform headaches with autonomic symptoms, or SUN. This is the classification of our headache disorders. Now from here, we will go to the most commonly asked subtype of it, which is migraine. Okay. Now whenever you write something about headache disorders, few things to note. What points we should mention, or what points examiners are looking for? First, you should mention whether the headache is unilateral or bilateral, because that holds the clue for diagnosis. Right? For example, the tension type of headache is bilateral headache. It is a bilateral headache. The migraine is unilateral. And anything that comes under trigeminal autonomic cephalgias are also unilateral headaches. So laterality is what he is looking for. Second thing, you have to mention the severity of the headache. And the third thing you have to mention is, once an attack of tension type or migraine or cluster happens, how long the attacks stay. These three things are crucial when you describe the clinical features of any headache type. Right? So we'll begin with migraine. Migraine, first word you have to write is, it is the second most common primary headache disorder. First is tension type, right? This is the second most common primary headache disorder. Which gender it is more common? It is more common in females than males. And what age group it affects? It typically affects middle-aged. It typically affects middle-aged. And it is characterized by episodic unilateral headaches with or without aura. With or without aura. So there are episodes of headache which is unilateral. And then in terms of severity, it is going to be moderate to severe. Moderate to severe. You have to please remember that migraine attacks cannot be mild. A mild attack is not usually counted as migraine. It is very bothersome, severe unilateral headaches. In terms of quality, it will be pulsating or throbbing in quality. It feels like these patients often come and say that, sir, fata ja raha. Pulsating or throbbing in quality. And the headaches are usually accompanied by, what accompanied symptoms? It can have nausea or vomiting and photophobia or phonophobia. What do I mean by photophobia or phonophobia? The patients, when they're going through migraine, they do not tolerate the loud noises and bright lights. Photophobia and phonophobia. Okay. Now here I want you to mention the migraine phases also, because migraine progresses through phases. You can put a beautiful flow chart or a line diagram describing migraine phases. The first thing that happens in a patient before even the headache starts is there is something called as prodromal phase. Prodromal phase. So what happens in the prodromal phase? Prodromal phase lasts for around 0 to 48 hours. So during this period, patients will have restlessness, irritability, and even sometimes they may be confused. So these are the symptoms that we can get in the prodromal phase. So after the prodromal phase, patient, if it is a classical migraine, patient will get into the next phase, which is called as aura phase. And aura, I want you to specifically mention, it lasts for 5 to 60 minutes. This is something that examiners are consciously looking for in the question, whether you know how long the aura lasts in a case of migraine. So you have to mention that aura lasts for 5 to 60 minutes. Okay, so what symptoms these patients during aura phase experience? They can experience flashing of lights or seeing zigzag lines in the visual field, right? Or seeing floaters, or even they can go through hemiplegia, or even they can go through blindness. These are the aura symptoms. After the aura is over, the headache comes. So the headache phase. Headache phase lasts for anywhere between 4 hours to 72 hours. I have already told you what examiners are looking for is whether you mention unilateral or not, unilateral or bilateral, the nature of the headache, severity, it is mild, moderate or severe. It is of course moderate or severe. Third thing is how long the attacks last. This is again an important point that examiner is looking for. 0 to 5 to 60 minutes as aura, and 4 hours to 72 hours of headache. So what happens in the headache? In the headache phase, patient will have unilateral pulsating severe headaches. Unilateral pulsating severe headaches. And after the headache phase is over, the story doesn't end there. Patient will also have what is called as post-dromal phase. In the post-dromal phase, what happens basically? In the post-dromal phase, same thing that he experienced during the prodromal phase, that is confusion, irritability, and low mood or confusion, restlessness, they will come back again to the patient. They will come back again to the patient. That is our post-dromal phase. So that completes our description of the clinical features of a patient with migraine. Now let us talk about its diagnosis and management. So how do we make a diagnosis of a patient with migraine? How do we make, or what points are required? So remember, the diagnosis of migraine is clinical. Diagnosis is clinical. We do not require investigation, right? Imaging or CT, MRI only if red flag signs which are suggestive of secondary headaches are present. Secondary headaches are present, like a patient who presented with unilateral headache, but he also has fever and neck stiffness. Then it is meningitis, right? Most likely meningitis. Those findings like fever, neck stiffness that is coming along with the headache, we will call them as red flag signs. So if they are present, I need to investigate. If not, I don't need to investigate. I can make a clinical diagnosis. Like if I get a typical middle-aged female presenting with repeated attacks of unilateral headache lasting 4 to 72 hours with or without aura, with nausea, photophobia, phonophobia, I will consider it as a case of migraine. Okay. Now here, if you want, you can also write the description of the clinical criteria, that there should be at least 5 attacks, describing each attack having 4 to 72 hours with nausea, vomiting, photophobia or phonophobia, but that's not what is required. As long as It is all covered in our migraine phases itself. Okay. So once the diagnosis is done, then comes the question of management. Now in the management, I want you to divide the management under two headings. The first one is, because it is a chronic disorder and there will be repeated attacks of migraine. There will be repeated attacks of migraine. Every time an attack of migraine happens, I need to treat it because headache is moderate to severe, intolerable to the patient. Second, I have to prevent attack from coming, right? So management, we will divide it in two headings. Acute management. What do we do in acute management? In acute management, we treat once an attack of migraine has set in. So how do I treat, right? So the first line management is of course an NSAID. A painkiller can be used, but they are generally not very effective. So we have to choose more potent NSAID like ibuprofen, which is strong, right? Ibuprofen or naproxen. These are strong NSAIDs. But if you ask me what is the drug of choice, NSAIDs are not. NSAIDs don't help for most of the patients. And I am not only telling it from the literature, but as a patient of migraine myself. So what will be the drug of choice? Currently, the drug of choice are triptans. And you can mention few examples like sumatriptan, which is available in the form of oral, right? Subcutaneous injection. It is also available as a nasal spray. Then we also have zolmitriptan, right? Razatriptan. You can mention 2 or 3 examples. These are triptans. These are considered as the drug of choice for acute treatment. Okay. Now coming to the preventive treatment. So for preventive treatment, we have the drug of choice, which is propranolol, or the beta blockers, which is propranolol. But you can also write other drugs that can be used for preventive treatment. So there you can mention flumazenil, which is a vestibular sedative. Flumazenil, which is a vestibular sedative. Then candicertan, which is a ARB, right? Okay. Then you can also mention botulinum injection. Okay. Then you can also mention valproic acid or valproate, which can also be used. And then there is something called as STMS, which stands for single pulse transcranial magnetic stimulation. So these are the options we have in addition to propranolol. The list is of course long. It's not a pharmacology exam, so don't try to write too much of the drugs or individual description of the drugs. Just give an outline when it comes to the pharmacological management. Okay, so that's about our migraine. Okay, so from there we will move to our next question. The next question is one of the very repeatedly asked question in all of our university exams, which is about stroke. Definition of stroke, classification of stroke into ischemic and hemorrhagic stroke, and then from there the question might lead to management of hemorrhagic stroke or management of ischemic stroke. Most universities ask you about the management of ischemic stroke. Sometimes they ask you about elaborate on the indications and contraindications for thrombolysis or newer advances in the management of stroke, right? So we'll begin there. We'll first try to define stroke. What is stroke? I repeatedly say this: stroke is not equal to hemiplegia, right? There are n number of causes for hemiplegia. So what is stroke? Stroke, we will define it as focal. Focal means some part of the brain, or diffuse means whole of the brain. Focal or diffuse neurological deficits means some part of the brain or whole of the brain is not working. Neurological deficits, or why is it not working? Because of some blood vessel pathology of vascular origin. And when I say vascular origin, there can be either a blood vessel getting blocked, resulting in some part of the brain or whole of the brain not getting sufficient blood supply. That's why it is not working. Or what else can go wrong with the blood vessel? Blood vessel can rupture and bleed. or hemorrhage. So when a blocked blood vessel or a bleeding blood vessel leads to loss of function of some or whole of the brain, then we will call it as stroke. Hemiplegia can happen because of a tumor, abscess, right? A bullet injury, and number of causes. But if hemiplegia happens because of ischemia or because of hemorrhage, then it is stroke, right? Or hemiplegia doesn't happen, but only Broca's area there is a bleed. I lose my motor speech function, that is also stroke. So any deficit of nervous function because of ischemia or hemorrhage, we will call it as stroke. Okay. Now, how do I classify this case of stroke? The stroke will be classified into two groups, ischemic and hemorrhagic. So the stroke, we will classify them into ischemic and hemorrhagic. Ischemic is where a blood vessel is blocked, not sufficient blood is being delivered to brain. So we'll have ischemic stroke and hemorrhagic stroke. Which is more common? Of course, ischemic stroke. So ischemic stroke accounts for 80 to 85% of the cases, and hemorrhagic stroke account for around 15% of the cases. So ischemic stroke is more common. Now under hemorrhagic stroke, what all comes? Under hemorrhagic stroke, we will have direct bleeding into the brain parenchyma, right? We'll call it as intraparenchymal bleed, means bleeding into the cerebrum, the main brain, right? Intraparenchymal bleed, or we can also have subarachnoid hemorrhage. This we will call it as ICH, right? Intracranial hematoma and subarachnoid hemorrhage or SAH. Now, if you are thinking, sir, why we are not including, only these two are included, why we are not including epidural hematoma and subdural hematoma in stroke? Well, we have already defined stroke. What is stroke? Stroke when some part of the brain doesn't work because of some blood vessels problem, then we will call it a stroke, right? Now, intraparenchymal bleed, right? What is the most common cause for bleeding to happen inside the brain parenchyma? The most common cause for intraparenchymal bleed is hypertension, right? Hypertensive bleed. Hypertension is a disease of what? It is a disease of blood vessel. So it is a stroke. Then subarachnoid hemorrhage. What is the most common cause? The most common cause for subarachnoid hemorrhage, spontaneous subarachnoid hemorrhage, is the rupture of berry aneurysm, right? Rupture of berry aneurysms. So what is this berry aneurysm? Again, it is a disorder of the blood vessel. So a problem of blood vessel has resulted in loss of function of the brain. So it is stroke. But epidural and subdural hematomas are not because of a problem of the blood vessel. They are because of trauma, right? Mostly why someone develops EDH or SDH, fall on the head or head injury. So then it becomes a traumatic cause. It is not a blood vessels problem. It's not a vascular pathology. It's a trauma. That's why they are not considered under stroke. Okay. The ischemic stroke will be further classified into thrombotic strokes and thromboembolic strokes. Thrombotic strokes and thromboembolic strokes. So basically in thrombotic strokes, the clot gets formed within the blood vessel, and in the thromboembolic strokes, a clot gets formed somewhere else in other part of the blood vessel or in the heart, and then travels through the circulation to reach the brain's blood vessel and block it. Then it is thromboembolic stroke, right? So for the thrombotic stroke, what are the causes? The causes for thrombotic stroke includes hypertension, diabetes mellitus, dyslipidemia, hypercoagulable states. These are all common causes, right? Hypercoagulability, smoking. The list goes on and on. You can write sedentary lifestyle, anything that comes to your mind, you can just go on adding here. So thromboembolic stroke is usually caused by atrial fibrillation, right? Atrial fibrillation is the most common cause for thromboembolic stroke, because during atrial fibrillation, left atrium doesn't contract. A clot forms in the left atrium. From there, it makes its way to internal carotid artery, from there to the middle cerebral artery, and causes stroke. So this is about our classification of stroke. Now we will go to the next part of the question, which is about the management of acute ischemic stroke. So when it comes to the ischemic stroke, The management should include the diagnosis and treatment part. So first we will begin with the diagnosis. And in the diagnosis, first thing that you have to mention is early recognition of stroke, because diagnosis is clinical. You recognize clinically and then confirm with investigation. So in the diagnosis part, first thing you should write is early recognition. Early recognition. How do we do the early recognition of stroke? So there is something called as B fast algorithm for the early recognition of stroke, and this is what examiners want you to write, where B stands for balance issues. If patient is lost balance, right? E stands for eye movements or vision issues. So if patient is not able to see, or some eye there is some vision problem, then it is E, right? Then F here stands for face. Face, if there is any asymmetry of the face, drooping of the face or facial asymmetry. A here stands for arm weakness. If patient has noticed weakness of any of his arms. Okay. S here stands for speech issues. Speech abnormalities. If patient has developed aphasia or slurring of speech. And T here stands for time. So if any of these findings are seen in a patient, without wasting the time, patient should reach the hospital. That is how we can recognize the stroke early. If patient only doesn't come to the hospital in time, then how can we recognize the stroke early, right? So this algorithm helps the patient or patient's family member to recognize that they are going through stroke and then bring them to the hospital. So as long as you put this nicely up there, your job is done with respect to early recognition of stroke. Okay. And once we have written this, we will go to the approach to the diagnosis. Once you recognize, I don't know that at this point of time it's a case of stroke. Whether it is ischemic or hemorrhagic, I don't know. So now the investigation will help me to identify whether it is ischemic or hemorrhagic stroke. So whenever I have a suspected case of stroke, what I should do? I have to image. What will be the imaging modality of choice? It is the CT scan. CT scan of the brain, which is plain. You can also write it as non-contrast CT scan of the brain. What it will do, non-contrast CT scan of the brain is highly sensitive for recognition of bleed. It is not a good investigation for the identification of infarction. At least in the first 6 hours, you see nothing on the CT scan in most cases. After 6 hours, the infarct becomes evident. But it is still the preferred investigation or the initial investigation of choice. For what reason? It is a highly sensitive investigation for bleed. And to differentiate whether it is ischemic or hemorrhagic, I just want to know whether there is bleed present or not. No bleed, I will call this stroke as ischemic. If bleed is present, I will call it as hemorrhagic. So if there is bleed present on the CT scan, then we are going to call it as hemorrhagic stroke. It is hemorrhagic stroke. And if there is no bleed, we will call it as ischemic stroke. Ischemic stroke. Right. In the investigation, you can mention that, if you want, you can mention that MRI is more sensitive for recognition of ischemic stroke, and you can mention CT is more sensitive for recognition of bleed. Okay, so that completes our approach to stroke. Now, once we know that it is an ischemic stroke, we will write little things about its management of ischemic stroke. Okay, of course, we don't have to write in detail like how we would know for the MCQ exam, but what you can write in the examination given the time that is given to you to write a 10-mark question. First thing you have to mention is initial management and two categories, initial management and definitive management. So in the initial management, we are talking about only ischemic stroke, right? So we will give dual antiplatelets antiplatelets. We're giving two antiplatelet agents, that is aspirin and clopidogrel. To be very frank, we decide to give antiplatelets only after deciding whether we are going for thrombolysis or not. No need to describe so much in your exam. Just write that, okay, we do give dual antiplatelets, whether after the thrombolysis, if you are going for thrombolysis, or as soon as patient comes, if you are not going for thrombolysis. No need to write all that. Just you can write dual antiplatelets. We can give statins. Okay, and then third thing I want to mention is no role of neuroprotective. Earlier we used to say that we can protect the neurons from dying, but right now there's no evidence to say that those agents which are marketed as neuroprotective are helpful. No role of neuroprotective agents like citicoline or edaravone. These are neuroprotective agents. Even if you don't remember the name, it's fine. Just mention that there's no role for neuroprotective agents in the management of stroke, right? Then comes the definitive management. So what we can do, there is a blocked blood vessel, there is a clot. Because of that, your brain is not getting blood supply. If I remove the clot quickly, I will re-establish the blood flow and I will be able to save at least some neurons from dying. But if I let the clot stay there, then large number of neurons will die. So basically, I'm trying to minimize the damage by opening the blood vessel. So opening the blood vessel is the definitive treatment. So definitive management is revascularization. Revascularization, which is nothing but opening of the blocked blood vessels. So there are two choices for us to do that. One of them is give a medication to dissolve the clot, or second, like there is a blood vessel, there is a clot, give a medication which makes the clot get dissolved, or instead put a wire and pull this clot out. So when we put a wire and pull the clot out, we will call it as mechanical thrombectomy. When you give medication to dissolve the clot, we will call it as thrombolysis. Thrombolysis and mechanical thrombectomy. So write one sentence describing what is it. So in thrombolysis, there is pharmacological dissolution of the clot, and in mechanical thrombectomy there is mechanical retrieval of, mechanically we are pulling out the clot, retrieval of clot using specialized catheters or devices, Okay, now we have to write about indications and contraindications for both of them. So we'll begin with the thrombolysis first. Thrombolysis. So under the thrombolysis, you have to write about indications, contraindications, and agents used. So what are the indications? Any patient of acute ischemic stroke, someone who is having ischemic stroke presenting within 4.5 hours of stroke onset. And like current edition of Harrison also mentioned that you can push it up to 6 hours. In select cases, up to 6 hours. Up to 6 hours. Even if you don't write, it's fine. 4.5 hours is the number that you have to remember. That is what most examiners are expecting you to write. Presenting within 4.5 hours of the onset of stroke symptoms. Okay. Now, what are the contraindications? Now, let us say a patient presented 3 hours after the stroke onset. It's an ischemic stroke. I should make sure that there are no contraindications. So the contraindication that you have to write, the first contraindication that examiner expects you to write is about BP itself. That is the most common scenario, right? BP more than or equal to 185 by 110 despite treatment. What does that mean? Means you can try to treat, you can try to bring it down. You're not able to bring it down, it still remains more than 185, 110, then it is contraindication. You can't do thrombolysis because there is risk of bleeding. Second contraindication is if there is any major surgery, recent major surgery. And again, when I say major surgery, I am talking about real major surgery like open heart surgery, open abdominal surgeries, or joint replacement surgeries. We're not talking about some lipoma excision or some simple cyst excision. recent major surgeries. Then the third contraindication is going to be rapidly improving symptoms. Rapidly improving symptoms. If a patient's stroke symptoms are improving rapidly, then it is a contraindication. Why? Because if the symptoms are rapidly improving, it may be suggestive of transient ischemic attack. So without your thrombolysis, within next half an hour or 1 hour, patient may get completely normalized. Means body itself is taking care of the clot, so you don't have to do it. That's it. Okay. Then fourth, very, very important. If you have written this, examiner will be more than happy to give you half extra marks. What is that? An infarct more than 1/3 of MCA territory. So if there is a large infarct, thrombolysis is not advisable. Means MCA has a territory, right? It supplies this much area of the brain. If more than 1/3 of that is affected by infarction, we should not do thrombolysis because there is a chance that in that infarcted area bleeding may happen. So that's why this is a contraindication. So these are the major contraindications you have to write. Words to concentrate on: despite treatment for BP and more than 1/3 of MCA territory. Okay. Now, what are the agents used for thrombolysis? Agents we can use: altiplase, retiplase, tonic-clonic, tonic-clonic. These are all agents which can be used. These are all TPA analogs, right? This can be used for the treatment of thrombolysis. Here, altiplase, they do expect you to write a little bit about dose. Not written also, it's fine, but if you're written, you can get that half extra marks. So if it is a 10-mark question, generally examiners give 6 for a decently written answer, but it can go to 7 if those extra points are added. So altiplase, the dose is 0.9 milligrams per kg, maximum is 100 milligram, right? 90%, 10% of this dose is given as bolus and 90% as infusion over 1 hour. Infusion over 1 hour. Just to make you remember, let us do some basic calculation. Like let us say I have got a 50 kg individual. How much dose I should be giving? 50 kg individual, 0.9 into 50 kg, it will become 45 milligrams. So I will be giving 45 milligrams of altiplase. Out of that, 10%, that is 4.5 milligram, I will give a bolus push. And remaining, that is 40.05 milligrams, I will give as an infusion over next 1 hour. That is our approach to thrombolysis. Okay. Now the next option we have for revascularization is mechanical thrombectomy. So what do we do in mechanical thrombectomy? So in mechanical thrombectomy, we remove the clot mechanically. Mechanical thrombectomy. Okay, so what are the indications for it? Indications are any patient with ischemic stroke presenting within 6 hours or up to 24 hours. Means the best result is possible when they present within 6 hours, but can be done up to 24 hours with a large vessel occlusion. Now what do I mean by it? See, your internal carotid artery bifurcates into anterior cerebral artery, middle cerebral artery. Middle cerebral artery goes on dividing into M1 segment. It has superior inferior division. This has M1 segment, M2 segment, M3 segment. Anterior cerebral artery also go on bifurcating. Now in this mechanical thrombectomy, actually we put a catheter or a wire into the brain's blood vessel and try to pull the clot out. So my wire can only reach the larger portion of the blood vessel. As it bifurcates and becomes smaller, it is difficult for me to pass a wire and remove the clot. So I can only do it if the clot is in a large blood vessel. So what can be considered as a large blood vessel? The proximal part of anterior cerebral artery or the M1, the first segment of the middle cerebral artery. Segment of the middle cerebral artery. And of course, anything that is there in the internal carotid artery. These are all large arteries where we can pass a wire and retrieve the clot. So if the clot is in a small vessel, this mechanical thrombectomy is not possible. So this is what examiner is expecting you in the write-up for the stroke management. Thrombolysis, mechanical thrombectomy, indications for both. Mechanical thrombectomy, what is the contraindication? Simple. The contraindication is a clot in a small blood vessel. Right. What are the contraindications for the thrombolysis? Recent major surgery, high BP, rapidly improving symptoms, and the infarct. You can also mention coagulopathy, right? PT, APTT being high or patient being on other anticoagulants becomes a contraindication. So that's about the stroke. Okay. So next question that we're going to take up is the seizures. Seizures. Okay. Ruhina said absolutely right. Absolutely right. Okay. So in the seizures, what do they expect? Some universities have seen questions where they're asking you to differentiate between the seizures and epilepsy. So of course, when you write about seizures, you have to tell what is seizure and what is epilepsy. After that, they may ask you to write a short note on a subtype of seizures, like for example, GTCS or absent seizures. If it is in medicine, it is mostly going to be about GTCS. If it is in pediatrics, it is mostly going to be about absent seizures, right? So we'll start with seizures. What is the definition of seizure? Any convulsion or an abnormal movement, involuntary movement is not seizure. Seizures can also happen without the movement, like you see absent seizures. So movement is not equal to seizure. That's something that we should be clear. So what should I write in the definition? Seizures are defined as abnormal, hypersynchronous, Yeah, for pharmacology, definitely that's a very, very important question, right? Anti-epileptic drugs. Hypersynchronous electrical activity, or you can simply write it as abnormal electrical discharges of the neurons, electrical activity of neurons, or you can also use the term brain. Abnormal means, see, normally when I want to do some movement and all, my brain is active and it is discharging the neurotransmitters or electrical impulses. That is normal. Abnormally, when it starts doing that, too not one neuron, right? They're like surrounding neurons are all synchronously, simultaneously discharging. Abnormal, hypersynchronous. These are the two words is important in the definition. Now, these neurons will lead to symptoms depending on which neurons are being affected. If it is motor neurons which are abnormally hypersynchronously discharging the electrical impulses, then my body will start moving. So I will have the seizures with convulsions or involuntary abnormal movements. But if it is happening in non-motor areas, like let us say it is happening in that part of the brain where I smell, then I will start perceiving abnormal smells. If it happens in the visual cortex, I will have visual abnormalities that I will be experiencing. So seizures can also have sensory symptoms, right? Any part of the brain can get affected by seizures. Okay, that's clear. So then seizures with abnormal movements will be called as convulsions. So seizures can be convulsive or non-convulsive, right? Then we will call it. Only when there are abnormal motor activity, then we will call it as convulsions. Then what is epilepsy now? Seizures can be because of a cause or without a cause. For example, if I have a tumor in the brain and tumor is irritating the surrounding neurons and the surrounding neurons are hypersynchronously, they are firing continuously, I will have a seizure. But the seizure is because of a cause, tumor. I can have a bleed, bullet injury, a calcified focus. So when there are identifiable causes for the seizure, then we will simply call it as secondary seizure. So seizure because of a cause. We will not call it as epilepsy. And when do I call it as epilepsy? There should be a seizure which is not provoked. There is no cause, but still patient got a seizure. Again, a single episode of seizure, we will still not label it as epilepsy. There should be at least 2 episodes of seizures without an identifiable cause. Then we will call it as epilepsy. So epilepsy, we will define it as more than or equal to 2 episodes of unprovoked Means there is no cause, there is no provocation for the neurons to start firing. Unprovoked seizures. And these seizures may be convulsive, non-convulsive, doesn't matter. They are at least, these two episodes are at least 24 hours apart, separated by at least 24 hours apart. Then we will call it as epilepsy. So now we know the difference between seizures, convulsions, and epilepsy. Any abnormal electrical activity of the brain is seizure. If that is involved in the motor system, it is convulsion. And the seizures, which have no cause, and at least two such episodes have happened, then we will call it as epilepsy. Okay. Now, how do I classify the seizures? The seizures are classified according to International League Against Epilepsy 2017. So the seizures are classified into two groups, the focal onset and generalized onset. Now, what do I mean by focal onset? This abnormal electrical activity in the brain may start in some part of the brain. Whether it remains only there or spreads to the whole of the brain is a different matter. But it is starting in only some part of the brain, then we will call it as focal onset. If it starts in whole of the brain, then we will call it as generalized onset. Now, as a doctor, how will I get to know whether it is focal onset or generalized onset? If whole of the brain starts abnormal electrical discharges, will the patient be conscious? Of course not, right? He will lose the consciousness. So the generalized onset is always associated with loss of consciousness. Always associated with loss of consciousness, because now my whole of the brain is abnormal now, not functioning properly. But focal onset may be associated with consciousness or may be associated without consciousness, depending on whether once it starts, remains there only or spreads. If it remains there only, like for example, let us say in the motor area of the brain, abnormal electrical activity started, one side of my body started moving abnormally. But electrical activity is only restricted to motor area. It is not spreading to the frontal lobe, temporal lobe. So I will not lose consciousness. Only the motor area of the frontal lobe is abnormal. So I will only have the seizures. I will not lose consciousness. On the other hand, from the motor cortex, it spreads to, let us say, frontal and temporal lobe. I will lose consciousness. So focal onset can be with loss of consciousness or without loss of consciousness. So if it is with loss of consciousness, we will call it as impaired awareness. Focal onset seizures with impaired awareness. The older terminology for this is complex partial seizures. Means it is partial, starting in some part of the body only, but we are adding the term complex because it is eventually leading to loss of consciousness. But if abnormal movements only some part of the body, patient is conscious, then we will call it as focal onset seizures without impaired consciousness, no LOC, loss of consciousness. You can simply call it a simple partial seizures. Why are we calling it as partial? Because only partially some part of the body is affected. And we are calling it as simple because there is no loss of consciousness. Okay. Now, focal onset are most commonly have a secondary cause. It's usually not epilepsy. There are epilepsies which can be focal onset, but most common cause for focal onset seizures is a direct cause there. Like, why should only some part of my body or some part of my brain become abnormal? Because there is a tumor or an abscess or a calcified focus or vasculitis or infection, something there. Okay. On the other hand, generalized onset will either have epilepsy or metabolic causes, means hyponatremia, right, or uremia, metabolic causes which affect the whole of the brain, or they have epilepsy. So epilepsy is most likely to be generalized onset than focal onset. Secondary causes of seizures are more likely to be focal onset. Okay. Now this generalized onset is further divided into motor seizures and non-motor. Means if movement abnormality is involved, then it is motor seizure. But many of them may not have any movement abnormality. Then we will call them as non-motor seizures. For example, you might have heard about something called as gelastic seizures. What do you mean by gelastic seizures? Those are the conditions where patients will not have any abnormal movements, but they will start laughing out loudly continuously. So that laughing out loudly is happening because the laughing area of the brain, which is supposed to regulate our response to laughter, is hypersynchronously discharging the electrical activity. Right? They are not having any other abnormal motor movements. It is a classical example. Then your absence seizures that you study in the pediatrics. Right? Absence seizures that you study in the pediatrics is a classical non-motor seizure. There is abnormal electrical activity of the brain, Of course, as I have already told you, during that period, if it is a generalized onset, there will be loss of consciousness. Patient momentarily goes blank. Once the seizure episode is over, he is back to consciousness. But during that time, there is no abnormal movement happening. Of course, this can be a 5-mark question in pediatrics. So in medicine, it is mostly about motor, generalized onset seizures. The motor seizures will be classified into tonic, clonic, atonic, and myopathic. Right? Let us try to understand the meaning of these terminologies. What do I mean by tonic? Tone is a term which we are familiar with, right? What is tone? It is a state of contraction of a muscle when it is not doing any contraction. Means a muscle is never completely relaxed. Even when we are not doing any contraction, it is partially contracted. That partial contraction is what we call as tone. Okay. So when we say tonic seizures, means the tone is increasing, means the muscles are becoming more and more contracted. They're not contracting and relaxing alternatively, they're just contracting. The tone is increasing. So all the muscles become stiff. So sudden stiffness of the muscles is tonic seizures. So all your muscles become stiff. Patients will start extending all their limbs. They have a tendency to fall backwards. Clonic. Clonic is the term that is used for the jerky movements. So when there is repetitive jerky contraction and relaxation of the muscles, we will call it as clonic seizures. Okay. Then we are using the term atonic. Tone which gets abolished completely. When tone suddenly increases, we will call it as tonic seizures. When tone goes away, we will call it as atonic seizures. I've already told you, tone is important for maintaining the body posture. When I stand, even when I'm not moving any muscle, my muscles are partially contracted so that I can stand erect upright. But if my tone goes away, my muscles get completely relaxed, I will fall down. So these patients with atonic seizures present with repeated attacks of falls. They were like talking to you and then suddenly their tone drops, they fall down. That is atonic seizures. Myoclonic seizures refers to small contractions or flickering contractions of the muscles. Okay, but these are all relatively less common. What is the most common type of motor seizure? The most common type is tonic-clonic, and because it comes under the generalized onset, we can also call it as GTCS, generalized tonic-clonic seizures, right? Now, why are we calling it as tonic-clonic? Because it is a combination of these two. How does that happen? Means, what is the clinical presentation? Tonic, I understand, suddenly all muscles become stiff for a few seconds, few minutes. Clonic, repetitive jerky movements. But what is this generalized tonic-clonic? Generalized tonic-clonic is where there's a phase-wise progression. First tonic, followed by clonic. So during tonic, all the muscles become stiff. After that, patient starts doing the jerky contractions, clonic. So just because going through phases, tonic first, followed by clonic, we will call it a generalized tonic-clonic seizures, which is the most common seizure, right? So the point that we need to write about the GTCS is, it is the most common generalized seizure, most common generalized seizure type. Okay, it progresses through phases. So what are the phases we get? The first is prodromal phase. You can write a small image trying to describe what all happens, just like migraine, right? So we will have a prodromal phase. During this period, again, patient can have confusion, restlessness, irritability, and irritability. And from this phase, they go to what is called as tonic phase. So then they enter into tonic phase. So what happens in the tonic phase? So in the tonic phase, there is sudden stiffness of muscles. There is sudden stiffness of muscles. Most of you might have witnessed at least someone going through the seizures, and you can relate to it. Like suddenly the whole muscles stiff, they fall and all muscles are stiff. Okay, and during this phase, many of them start making loud noises from their throat, right? So that is called as epileptic cry. It's called as epileptic cry. That is because even your vocal cords or laryngeal muscles are contracting, right? They are also in tight contraction. They are also stiff, and then when the breath air escapes from that, it makes a cry like sound. called as epileptic crack. So after the tonic phase, which may last for few seconds to few minutes, patient enters into clonic phase. Clonic phase. So in the clonic phase, as we already know, there will be repetitive jerky movements. Repetitive jerky movements. And after the clonic phase is over, patient will go into the next phase, which is called as postdromal phase. We will call it as postdromal phase. What happens in the postdromal phase, or you can also call it as post-ictal phase. Similarly, the prodromal can also be called as pre-ictal phase. Pre-ictal refers to seizures, right? So whatever happens during the seizures is an ictal phase. Before and after that is pre-ictal, post-ictal phase. You can also write it as postdromal phase. Now what happens in this case? The patient will have drowsiness because all of his brain neurons have exhausted their neurotransmitters. So patient can experience drowsiness. Patient can also experience muscle weakness because muscles also have exhausted all their glycogen store and energy. Neuromuscular junctions have exhausted all their neurotransmitters. And the muscle weakness can also be called as Todd's palsy. Todd's palsy. Muscle weakness after an episode of seizure is called as Todd's palsy. So this is about the phases through which the GTCS progresses. Okay. Now coming to what can cause it. Right. Among the causes, first thing you should mention is epilepsy. Because for epilepsy, we don't know the cause. Basically, epilepsy is a form of idiopathic seizure, you can say. Epilepsy. And then secondary seizures. And in the secondary seizures, it can be either because of intracranial space occupying lesion, right? It can be because of metabolic brain disorders or metabolic encephalopathy. It can be because of intracranial bleed, right? It can be because of the meningitis or encephalitis. It can also be because of the brain abscess, and sometimes it can also be a complication of stroke or basically brain scarring. The stroke or infarcted area is scarred, right? That can also become a focus for generation of seizures. These are secondary causes. Epilepsy is where we don't know the cause. Now, how do you manage a case of generalized tonic-clonic seizures? So in the management, primarily you have to mention what is the first line agent and what are the other agents that you can use, right? So in the management, currently we consider valproic acid as the drug of choice, or sodium valproate is the drug of choice, and other agents that can be used include carbamazepine. So when I started my MBBS, carbamazepine used to be the drug of choice for the generalized tonic-clonic seizures, but because of its side effect, it has been sidelined now. Carbamazepine. You can also use lamotrigine. Okay, you can make definitely another long list of anti-epileptic drugs. But what examiner is looking for is valproic acid should be mentioned. If you have time, you can also write few words about valproic acid side effects. Means what monitoring needs to be done. Valproic acid is known to cause alteration in the liver functions, and that is why LFT should be monitored, and valproic acid is known to cause weight gain. These two things you can mention if you have. Okay, so that is about our seizures. Similarly, the question, instead of leading to GTCS, it may lead to absence seizures. For absence seizures, please refer to the pediatrics lecture. Sir would have described it in sufficient detail. Okay, so let us take up the next question. Another 5 or a 10 mark question is going to be on meningitis, right? So this can be a 5 mark or 10 marks. Let us see how we can write it for 10 marks. So if meningitis is asked for 10 marks, it will talk about definition and classification. In the classification, primarily you should be describing bacterial, fungal and viral meningitis and the other causes. And then it will invariably lead to either write on management of bacterial meningitis or fungal. If it is fungal, then it is most likely going to be a 5 mark question. And if it is bacterial, then it can be a 10 mark question. Right? So for definition, we are going to put 1 mark. Classification, 2 marks. Then when it comes to acute management of bacterial meningitis, there includes the description of investigation, where you have to write about the interpretation of CSF analysis. For that, 2 marks, and the remaining marks for the management. In the management, examiners do expect you to write about the antibiotics of choice. Okay. So let us assign 7 marks for the rest part, right? So what is meningitis? By definition, meningitis refers to not the infection, inflammation of meninges, that is meningitis. Inflammation of the meningeal layers is meningitis. Now this inflammation can either be because of infection or non-infective causes. So that is why in the classification of meningitis, first thing you should write is meningitis will be classified into infective and non-infective. Okay, can anybody give me examples for the infective, non-infective meningitis? Infective, non-infective. Can a patient with rheumatoid arthritis, SLE, end up developing meningitis or a carcinoid syndrome? Yes. One of the complications of SLE or rheumatoid arthritis, or for that matter, many rheumatological disorders, is development of meningitis, because the inflammatory cytokines that are formed in those conditions, they can also cause the damage to meninges, just like how they cause pericarditis, pleuritis, peritonitis. They can also cause meningitis. So non-infective include SLE, rheumatoid arthritis, and then when cancer spread to meninges, like cancer found elsewhere in the body, but then deposits will happen to the meninges, body will try to mount an inflammatory response in presence of those deposits. So there will be inflammation of meninges. So in that case, we will call the condition as meningeal carcinomatosis. Carcinomatosis. So these are all non-infective causes. The infective causes we will divide into bacterial, fungal, viral, bacterial, fungal, and viral. And then, though it is technically bacterial, tubercular is put as a separate category because the management presentation all differs. So we'll have 4 categories under the infective meningitis. Then the point next you should write is, among them, the most common is the bacterial meningitis. Most common is bacterial meningitis. Okay. So we'll take up one by one. We'll start with the bacterial meningitis first. Okay. Before that, let us write a little bit about clinical features of meningitis. The clinical features are not going to be different. If it is bacterial, the symptoms are going to be different, or if it is fungal, the symptoms are not, they're not going to be different just based on the etiology. They are going to be relatively same. So what clinical features the patient present with? In terms of symptoms, what do we expect? We expect something called as a triad of meningitis. So what is this triad of meningitis? Patients will have headache, fever, and neck stiffness. These are the common symptoms, right? We will call it as triad of meningitis. But when someone presents with this triad of meningitis, of course, I will do the clinical examination, right? So on examination, what findings I will get? So the first finding I will notice is that there is nuchal rigidity or neck stiffness. Difficult to make the flexion extension movement of the neck, nuchal rigidity. Then there are 2 signs that you should write, and if you can describe it, it is even better. What are those? Kernig's sign and Brudzinski sign. Kernig's sign, and the second one is Brudzinski sign. Okay, I will try to help you remember these signs better. So basically what happens when there is inflammation of the meninges? The meninges are highly irritated. So when I try to stretch the meninges, it hurts, and the patient subconsciously will try to restrict the stretch of the meninges. Right now, how can I stretch the meninges? Can I stretch the meninges of the brain? No. Can I stretch the meninges on the spinal cord? Yes, because my spine can be moved, right? Let us say this is the patient's vertebral bones or the spine, and I have the the spinal cord here, right? And around that I have the meningeal layer. So if I try to somehow stretch the spine, then even the meninges will be stretched and that triggers the pain. And to avoid that, patient wants to restrict the stretching of the spine. So when any maneuver where I try to stretch the spine, patient will try to restrict it. And both these Kernig's as well as Brudzinski are same. They are the maneuvers where we are trying to stretch the spine. Okay. So what do we do in Kernig's sign? In Kernig's sign, we ask the patient to lie down flat on a bed. Okay. And then we will flex his hip at 90 degree and knee at 90 degree. And from this position, we will ask him to extend the knee. Extend the knee. And knee extension, see, remember his hip is flexed at 90 degree, knee is flexed at 90 degree, and from there we are trying to further extend the knee. Knee extension beyond 135 degree, right, triggers pain. Then we will say Kernig's sign is, that indicates that the Kernig's sign is positive. Kernig's positive. Why is that happening? Because when I try to extend the knee further, right, it will stretch the spine, and when the spine is getting stretched, the meninges on the spinal cord are also getting stretched, and the inflamed, irritated meninges will trigger the pain. So patient will try to restrict the stretch. You will encounter the rigidity or resistance, or patient will say it hurts. Okay. Now what do we do in Brudzinski sign? Here also we are trying to stretch the spine. Instead of trying to stretch it from the lower end, we are trying to stretch it from the upper. So what we will do is, we will take the patient's neck and then we will try to suddenly force flex. There is forceful flexion of the neck, and when we try to forcefully flex the neck, I am stretching the spine, so that is going to irritate the meninges. So he wants to restrict the stretch. How he can restrict it? You are trying to stretch on the other side, he will try to shorten the spine from the other end. How he can shorten the spine? So ideally he should be in a flat position, but he will try to shorten the spine by flexing his hip and flexing his knee. So on forceful neck flexion, of course don't do, when I say forceful, it doesn't mean that do it at a force that can literally cause dislocation of the atlantoaxial joint, but it should not be like very light. Just do little bit, and then the response will be, there will be flexion at hip joint and there will be flexion at knee joint. This is a response to forceful flexion of the neck. This patient is basically trying to restrict the spine stretching. You're trying to stretch it on the head end. By shortening his limb, he is trying to reduce that stretch. Then we will say that his Brudzinski sign is positive. Brudzinski sign is positive. These are the two signs you should describe. If you can make these sketches quickly, it gives an idea what you mean to the examiner. You can write a sentence saying that Kernig's sign is where the patient hip is flexed at 90 degree and then the knee is also flexed at 90 degree, and trying to extend the knee from this position. Going beyond 135 degrees becomes difficult, where patient starts experiencing the pain or he starts resisting the movement. Then we will say Kernig's positive. You can write it or you can just do this sketch. Similarly, Brudzinski sign, you can describe it as saying, sir, on forceful flexion of the neck, there will be a flexion response at the level of hip joint and the knee joint, as if the patient is withdrawing the limb to himself. It is called as Brudzinski positive, or you can just sketch this image. Okay. So once we have made a clinical diagnosis based on these symptoms and the signs, then comes the investigations for a laboratory diagnosis. So how will I investigate? Of course, the investigation of choice is CSF analysis, right? But for the CSF analysis, I need to do the lumbar puncture. But there is one caveat here. What is the caveat? Patients with meningitis will often have raised intracranial tension. Why raised intracranial tension? We have a very rigid skull, right? In that rigid skull, we have the brain, and around the brain, we have the meninges. Now, because of this meningitis, the meninges are inflamed, so they are occupying the space inside the brain. And the inflammatory cytokines that are formed in the meninges, they will also affect the brain parenchyma to some extent. So there will be inflammation of the brain parenchyma also, at least in few patients. So when brain is getting swollen and meninges are getting swollen, they are taking more space. So space is getting reduced inside the skull, and skull cannot expand. So pressure inside the cranium starts increasing. This is what we call as intracranial hypertension, right, or raised ICT. And at this point of time, when you try to do the CSF analysis, right, you are basically trying to get the CSF from the spine. So when I tap the fluid from here, the pressure here decreases. And once the pressure decreases, the physics says that fluids or fluidic substances, including gases, will move from higher pressure to lower pressure zone. So here pressure is high, here pressure has been suddenly decreased because we did the lumbar puncture and we removed some fluid. So then the brain wants to go down in this direction. This is what we call as brain herniation. But then the medulla oblongata is the restricting factor. So the brainstem can get stuck here, which is brainstem herniation, which can become a reason for death. So of course, I do not want to push my patient to death, at least in the situation where we know that any minor mistake, or sometimes no mistake also, doctors get beaten in this country. So of course, I do not want to take that risk. So I should make sure that I'm on the right track before the lumbar puncture is done. How do I establish that the intracranial tension is not so high that it will cause brainstem herniation? So for that, I have to check whether there is cerebral edema, whether the brain is swollen or not. How can I check it? There are two methods. Ideal method is doing the CT scan of the brain, which can tell me whether there is cerebral edema or not. Or alternate method, when CT scan is not possible, is to do the fundus examination. So you have to write that there is a prerequisite. Means this has to be done before lumbar puncture is done. For lumbar puncture, what is that? Either you have to CT brain you have to do, or fundus examination, because the fundus is what? The optic disc. What is optic disc? Optic disc is the end portion of your optic nerve, and optic nerve is extending into the brain. So if there is cerebral edema, optic nerve edema will be there. That edema will be seen in the optic disc edema, what is called as papillary edema, right? So we are doing either fundus examination or the CT brain to rule out cerebral edema, which basically indicates raised intracranial tension, right? So on fundus examination, what are we looking for? Papillary edema. So you can write saying that LP should be done once CT rules out cerebral edema, or fundus examination rules out papillary edema. There is no papillary edema, or CT doesn't show cerebral edema, then I am ready for the lumbar puncture. Once we have written this, now we will talk about the CSF analysis. Of course, you can write a lot of parameters, but you will not get so much time to write everything about CSF analysis. We'll focus on the key parameters. What are the key parameters? Key parameters we're looking at is the cell count, then differential count, CSF protein, and CSF glucose. CSF protein and CSF glucose. We will put a table mentioning the values that we can encounter in different types of meningitis, including normal circumstances, right? Normal bacterial meningitis. Remember, bacterial meningitis is also called as pyogenic meningitis. So don't get confused if they use the term pyogenic. Fungal meningitis, viral meningitis, and tubercular meningitis. Viral meningitis and tubercular meningitis, or TBM. Okay. So what is a normal cell count? Less than 5 per high power field. Okay. The cell count is going to be less. Even if you're not doing microscopy, less than 5 per cubic millimeter if it is a cell counter. Differential count is immaterial when we are getting less than 5 cells per cubic millimeter. CSF protein is generally less than 45 milligrams per deciliter, and CSF glucose is more than or equal to 2/3 or 60% of blood glucose. There is no defined normal value depending on your blood glucose. You're diabetic, if it is 300, then 60% of it, roughly 60% of 300 is 180. 180 equal to 180 or more than 180 is what we expect in the CSF. Okay. Now what happens in bacterial meningitis? Bacterial meningitis, the main cells that are going to respond to bacteria in the meninges is your neutrophils. So you will have a neutrophilic predominance, cell count will be increased. The bacterial meningitis will have cells ranging from 100 cells to thousands of cells. 100 cells, like it can be like 100, 110, 120, or it can be even going into thousands, like 1000, 2000, 3000. And differential count will show neutrophil predominance. Neutrophil predominance. Okay. The CSF protein will be significantly increased in a bacterial meningitis because body will be producing a lot of antibodies as well as inflammatory cytokines. Right? Cytokines are, many of them are peptides in nature. Okay, and the CSF glucose, because bacteria actively take up glucose from your CSF, the CSF glucose will be low. It will be decreased, or it can even be zero. It can be either decreased or zero. Means that much glucose may be taken up by the bacteria. Okay. Then in case of fungal meningitis, the cell count is not going to be in terms of thousands. It will be from tens to hundreds, right? You can get some 70, 80, 90, or maybe 100, 150, 200, 250 in terms of hundreds, not in terms of thousands. And this will have lymphocyte predominance. So now the remaining, all the meningitis will have lymphocyte predominance. So whether I'm talking about viral meningitis, tubercular meningitis, or fungal meningitis, they will have lymphocyte predominance. So neutrophil predominance is one point that helps me to recognize bacterial meningitis. Okay. Now in fungal meningitis, the CSF protein will be increased, but not greatly, minimally, right? I can see the CSF protein even in terms of grams. Normal is less than 45 milligrams. Even in terms of grams in bacterial, and sometimes even in tubercular. Here it is not going to be in grams, but from 45 it may become 60, 70, 100, 200. You can have some degree of increase. The CSF glucose is most likely going to be normal or minimally decreased. For example, you just write normal because fungi are not rapidly dividing, so they don't take up too much glucose. They're dividing very slowly, so they take up less quantity of glucose. So the CSF glucose doesn't drop drastically. Okay. Then viral meningitis, again it is lymphocytic predominance, and cells will be similar to fungal. Then what is the difference? The protein can be normal. In many cases, it is going to be normal, or if it is increased, it is going to be minimally increased. And the glucose, viruses do not require too much glucose for their replication, so CSF glucose will be perfectly normal. Okay. Then in case of tubercular meningitis, again the cells are going to be same as viral or fungal, from tens to hundreds. What is the differentiating feature? The protein will be relatively much higher than what we got in viral or fungal meningitis, and the glucose is often decreased. May not be as low as zero, but it is decreased because in tubercular meningitis, to contain the tubercle bacilli from spreading out, bodies try to create granulomas, and granulomas is nothing but an active colony of cells. The cells require glucose, so they are going to use the glucose from the CSF. Okay. So this is the CSF interpretation. So try to put this table. The way to remember is point about bacterial meningitis, neutrophils, thousands of cells, very high protein, very low glucose. The only other condition where you have low glucose is tubercular. Remaining fungal and viral, you can just write the same thing. Right. Then you may ask, sir, how will I differentiate between fungal or viral? Of course, the presence of risk factors, the nature of presentation. If a person with no risk factor presents to me with meningitis, I will think of viral with all this CSF picture. But if someone with immunocompromised state presents with a similar CSF picture, I will think of fungal meningitis. Okay. Now, once we have recognized, of course, there are other investigations that we can do for the diagnosis for or further confirmation. For bacterial, we can do culture. Fungal, we can do like cryptococcal meningitis. We can do India in preparation. We have cryptococcal antigen test. For tubercular meningitis, you can check the ADA levels in the CSF, which will be generally high, more than 10 units per liter, right? And for the viral meningitis, we can do the PCR. We can definitely write about it. We will write when we take the individual. It will start about the management. Will start with the bacterial. Okay. So bacterial, we will talk a little bit about the causative agents. Okay, and then because without knowing the causative agents, understanding and remembering management becomes difficult. So what are the causative agents? The first agent I want you to remember is the Streptococcus pneumoniae. Streptococcus pneumoniae. Rohina, Rashid, I will share a small table where all the drugs of choices for individual seizure types will be mentioned. Streptococcus pneumoniae. Then you have the Neisseria meningitidis. Then you have Staphylococci, Staph aureus, which may include the methicillin resistant variants also, MRSA, right? Then you can have Listeria monocytogenes, Listeria monocytogenes. You can also have Klebsiella pneumophila, and the list goes on and on. These are the important organisms you have to mention. And then I want you to remember some extra points. Streptococcus pneumoniae is the most common cause for bacterial meningitis, and the Neisseria meningitidis, which is also called as meningococci. This is called as pneumococci. Meningococci is the second most common cause for bacterial meningitis, and collectively they account for more than 75% of all cases. I am emphasizing it again. We need to know this to remember the antibiotics better. Otherwise, we have to buy it. Right? What is the most common cause? Streptococcus pneumonia. Half of your meningitis cases are because of pneumococci. Another 25% are because of meningococci. All other organisms, including fungal, tubercular, viral, account for only 25% of all your cases of meningitis. Okay. Then an extra point I want you to remember here is that the Staph aureus is increasing incidence. Means we have started seeing more and more Staph aureus meningitis cases. Maybe in future Staph aureus will supersede the meningococci and maybe it become the second most common cause. But as of now, it is meningococci followed by Staph aureus. Again, a very, very important point why I am mentioning it, because when we have to treat someone empirically without knowing which bacteria is responsible, I have to cover Streptococcus pneumoniae because that is most common. I have to cover Neisseria meningitidis because that is second most common. And now that these cases are rising, we have to also cover this. So whenever we treat a patient of meningitis empirically before culture is available, we have to cover these three bacteria. Our antibiotics should be able to target all these three. Then Listeria monocytogenes, right? Common among elderly, especially aged more than 55 years. It's also common among the newborns, but of course that's a pediatric problem. We'll restrict to medicine. Okay. Klebsiella is common among alcoholics. Common among alcoholics. Because alcoholics tend to develop Klebsiella pneumonia. From there, the Klebsiella gets into blood. From the blood, it goes to the meninges. Okay. So these are the causative agents. So how will I make a diagnosis of a bacterial meningitis? Bacterial meningitis, CSF will show like neutrophil predominance, and then it will show grossly elevated CSF protein, and it will show low, very low CSF glucose, very low CSF. Okay, now how will I manage these patients? Bacterial meningitis. Management itself carries usually 5 marks, or it can be a separate 5 marks question. Management of bacterial meningitis. First thing is empirical antibiotics. We have to start antibiotics empirically because delay in initiation of antibiotic increases the risk of death in meningitis patients. Empirical antibiotics. You can't say that, sir, I will do the culture, after 3 days the culture reports will come and then I will start the antibiotics, because delayed initiation of antibiotics is associated with high mortality. Antibiotics is associated with high mortality. So first I have to start empirically, and then based on the culture I can tweak or adjust. If it is not sensitive, I can change to something else. If it is sensitive, I can continue. Or if only one particular antibiotic is sufficient, I can stop the other antibiotic. But to start with, I have to start empirical antibiotics. Now, how do I make a choice, right? So here we can put a table about the empirical choice of antibiotics. Empirical antibiotics in meningitis. Biotics in meningitis. I forgot to mention one important organism, which is again a concern, which is Pseudomonas. Pseudomonas. Pseudomonas is more common in hospital acquired cases or penetrating head injury cases, because Pseudomonas is something that does not easily infect a healthy individual. Pneumococci, comfortably, right? I can get a pneumococcal pneumonia, from there it goes to the meninges. Even Neisseria meningitis can easily infect even a normal individual. That's why for Neisseria meningitis, there is also a need for prophylaxis for exposed individuals. But Pseudomonas typically affects diabetics or patients with uncontrolled sugars, diabetics, or patients who had been to hospitals. It's a hospital acquired infection. So if you are getting meningitis, it's mostly you're acquiring it in the hospital. You had a prolonged stay in the hospital, you got a lot of exposure to Pseudomonas and it infected you, or it exists in the universe comfortably. Plenty of Pseudomonas bacteria are there around our vicinity, but it tends to not infect us because our immune system takes care of it. But if I directly implant it into the meninges because of a penetrating injury, then it can cause. So penetrating head injury or hospital acquired cases where Pseudomonas is a concern, because if it is a hospital acquired meningitis or following head injury, I have to also cover these organisms. So for the empirical choice of antibiotics, let us divide meningitis into hospital acquired and community acquired. Okay, so we can divide them into community acquired, where there is no exposure to hospital, right? Community acquired or hospital acquired. Now for a community acquired meningitis, right, what organisms are commonly responsible, and I need to cover them with antibiotics? Streptococcus pneumoniae, Neisseria meningitis, and Staph aureus, right? These three are common for most people. But if it is an elderly, there is an additional problem, that is Listeria. So these are the 4 organisms I need to keep in mind. So if it is community acquired, I have to look at the age of the person. If age is more than 55 years, then there are an additional Listeria as a concern. But if age is less than 55 years, then what are the concern organisms? Concern bacteria or concern organisms? Pneumococci, that is Streptococcus pneumoniae. Then I have meningococci, that is Neisseria meningitis. And then I have Staph aureus, including MRSA, right? Including MRSA. And if it is a case aged more than 55 years, these 3 are definitely concerns. But in addition to that, I also have an additional concern, which is Listeria monocytogenes. So I have to cover the Listeria also for these patients. So age more than 55 years, age less than 55 years, an additional concern. So what antibiotics I can choose for empirical here? Pneumococci and meningococci are well covered by ceftriaxone, right? So I can use ceftriaxone to take care of pneumococci and meningococci. But for MRSA, what should I use? What is the drug of choice for MRSA? Vancomycin, right? Can I use linezolid? No. Linezolid is a good drug, but it has poor blood-brain barrier penetration. That's why it is not preferred. I need a drug that penetrates the blood-brain barrier. So we will be using our vancomycin. So ceftriaxone plus vancomycin will be the combination that we will initiate empirically for a community acquired meningitis with the age of the patient being less than 55 years. But if it is community acquired but patient is elderly, then I have to also cover listeria. Remember, the drug of choice for listeria is going to be ampicillin. So ceftriaxone, vancomycin do not work well for listeria. So I will be treating these patients with ceftriaxone plus vancomycin plus ampicillin for listeria, right? Highlight it so that it goes to the attention of the examiner, and you are telling him that I precisely know how do I manage a case of bacterial meningitis. Okay. Hospital acquired, in addition to these concern organisms, I have an additional concern which is Pseudomonas. So I need to cover Pseudomonas, right? Clear? And the same concern also arises for patients with penetrating head injury. So for hospital acquired or for patients with penetrating head injury, our concerned organisms are, of course, these organisms are the concern, but in addition to that, all these are concerned. But in addition to that, I have one more concern, which is Pseudomonas. So we have to mention Pseudomonas here. Highlight it so that the examiner knows that you know it. And now what antibiotics I need? Vancomycin will definitely take care of my MRSA or Staph aureus. I need ampicillin for listeria. And ceftriaxone, if I give, it may take care of pneumococci and meningococci, but it doesn't cover Pseudomonas. I need anti-Pseudomonal antibiotics. That too, those anti-Pseudomonal antibiotics which have the ability to penetrate the blood-brain barrier. The most commonly used anti-Pseudomonal antibiotic is the piperacillin tazobactam, but it does not penetrate the blood-brain barrier. So what I should use? Something which is capable of penetrating the blood-brain barrier. That can be either carbapenems or meropenem, imipenem, or it can be the fourth generation cephalosporins like ceftazidime. So here, if I'm using meropenem or ceftazidime, it does everything that ceftriaxone does. In addition to covering Pseudomonas, it will take care of pneumococci, meningococci. So should I continue with ceftriaxone? No, right? So I'm replacing ceftriaxone here with ceftazidime, or you can write any of the fourth generation cephalosporin with blood-brain barrier penetration, or you can use meropenem, which is a carbapenem, to take care of Pseudomonas, plus vancomycin for the MRSA, plus ampicillin for the listeria. So this is a cocktail that we will be using whenever we have a patient with hospital acquired meningitis or penetrating head injury. This is empirical antibiotic. Okay. Then in addition to antibiotic, what else we can do for bacterial meningitis? Is there any role of steroids? So mention that steroids indicated. Why are they indicated? Because they decrease meningitis sequelae or complications. What are those? Patients with meningitis often develop sensory neural hearing loss, and many of them develop decline in their brain function, cognitive dysfunction. They can be reduced by use of steroids. Use of steroids is perfectly safe in a case of meningitis. Now you don't have to mention the dose, duration, immaterial, but at least this much you should mention. So that covers our description of bacterial meningitis management. Okay. Then let us also talk about little bit about fungal meningitis and tubercular meningitis. Okay, so fungal meningitis, what extra point you should be writing? Mainly the risk factors. Fungal meningitis doesn't happen in a normal individual easily, right? So what are the risk factors? The immunocompromised state. Immunocompromised state. So what all you will mention under immunocompromised state? It can be because of HIV, and in HIV when the CD4 count is less than 200. CD4 count less than 200, right? Where else you can have immunocompromised state? In patients with cancer. Cancer compromises their immunological status. Third, patients on chemotherapy, steroids, or immunosuppressants. Immunosuppressants. Second is uncontrolled diabetes. Uncontrolled diabetes. Okay, now what are the causative agents for the fungal meningitis? Risk factors done. Causative agents. So in these individuals, what fungi can cause meningitis? The most common one is the cryptococcal meningitis, which is caused by Cryptococcus neoformans. And then we have coccidioidomycosis. And in the recent times, we have started seeing Candida, especially the non-albicans species. So these are common causative agents, which are even histoplasmosis, and the list goes on. They can cause fungal meningitis. Okay. So how do I make a diagnosis of a patient with fungal meningitis? Of course, CSF only. So what CSF analysis is going to show? So the CSF analysis will show first the lymphocyte predominance, as you have mentioned earlier, lymphocyte predominance, right? Increased protein, not as grossly increased as normal, or minimally decreased CSF glucose, minimally decreased CSF glucose. But this could also be viral, right? Similar picture you will get in viral. So what will help us to differentiate? We can do additional investigation. What is that? India ink preparation or cryptococcal antigen test. What would we prefer? Cryptococcal antigen. India ink preparation is having lower sensitivity. Cryptococcal antigen has a higher sensitivity in recognizing cryptococcal meningitis. So once we have diagnosed, how do we manage these patients? Management of fungal meningitis. We need, of course, antifungals. Fungal meningitis, right? We will be treating them with antifungals. What antifungals we will use? So we'll have a initial management followed by maintenance treatment. Means fungal meningitis, as long as patient is in immunocompromised state, it will strike back. So as long as he is in immunocompromised state, we need to have a preventive treatment or maintenance treatment. So for initial management, generally we use a combination of amphotericin B. This is considered as the drug of choice, plus flucytosine. That is our initial management. For maintenance, we can use fluconazole. How long I should give the fluconazole? As long as patient is in immunocompromised state. For example, if I'm talking about diabetic, as long as sugars are uncontrolled, as long as the target HbA1c is not reached. If I'm talking about HIV, as long as the CD4 count is less than 200. If he is maintaining CD4 count more than 200 for at least 6 months, I can stop giving him fluconazole. Okay. So this is about the fungal meningitis. Now the next thing we will talk about is the tubercular meningitis. So in terms of management of tubercular meningitis, just mention ATT for 12 months. So currently ATT is recommended for 12 months for the meningitis. And if we are talking about viral meningitis, the management is going to be symptomatic. Let us also mention about the diagnosis of tubercular meningitis and the risk factors, so that even if they ask to write little about TBM, you should be able to write. So the risk factors for TBM. So what are the risk factors for tubercular meningitis? First thing you should mention is TB elsewhere, means they have tuberculosis elsewhere, like pulmonary TB, lymph node TB somewhere else, right? Or the second risk factor is close contact with open case of TB. What do I mean by open case of TB? Someone who is coughing out and bringing out the acid fast bacilli, right? Okay. And then third risk factor is lower socioeconomic status. Socioeconomic status. These are the risk factors for TB meningitis. How will I make a diagnosis of TB meningitis? The CSF. The CSF analysis in TBM will show, first, it will show that it is lymphocyte predominance, right? Increased protein and decreased glucose, and you can have also increased adenosine deaminase levels, ADA levels in the CSF, and we can also do the CB0 or the PCR, which can be positive for the TB bacilli. In terms of treatment, we are giving ATT for 12 months. Viral meningitis, in terms of CSF analysis, as we already know, it will show lymphocyte predominance, increased or normal proteins, and normal glucose. In terms of management, it is usually self-limiting. So I want you to mention this term, that it is self-limiting, but you can treat it with IV acyclovir. Hassen's recovery means if you give acyclovir, the recovery will be fast. It doesn't mean that patients with those who are not treated with acyclovir won't recover. The recovery chances or survival coming out of meningitis is equal whether I give acyclovir or not. But if I give acyclovir, you will spend maybe 1 day or a half a day less with the meningitis symptoms in comparison to someone who is not being treated with the acyclovir. So that completes our description of the meningitis. So whether they're asking you to write a short note on viral, bacterial or fungal, you should be able to write it from the description that we. Okay. So with that, we will conclude the today's discussion. So we discussed the 7 important questions. There are also some minor questions that can be asked from the neurology side. It is all available on the Farre notes section. So you can go to the MedEd app where you can go to the Farre Prop 4 section, and in that medicine, neurology, all 10 and 5 marks questions that can be asked, you will be able to get the notes. Okay. So with that, we'll conclude today. Tomorrow we will take up the questions from the nephrology. Right. And someone was asking me about the drugs of choices. I will share a table in the Telegram group. You can go through the drugs of choices for individual epilepsy, so that individual seizures, I should not use the term epilepsy, so that if the examiner is asking you to write short note on those individual types for 2 marks or 3 marks, you should be able to deal with it. Okay. So see you soon, guys. Good night.